Open. Good morning, everyone. Hi, thank you for coming. I am Brett Kay at NCQA. Welcome, and thank you for coming here. I just want to give a couple of quick housekeeping announcements and things, and then we will go ahead and get started with the formal program. The first one is I understand that some people are having issues with WebEx, and I know you guys are communicating with many of your employees. So the issue is that there was, they may have been using an older number that was incorrect for the conference number. So I have the new number. I'd like to read that to everyone. Hopefully, I'm not sure if they were able to dial in, but if they're at least on the phone but not able to get in through the WebEx, the new number is, for the meeting conference ID is 992-272-827. And there's no password. So once you dial that, and that's the meeting number, once that should then allow you, again, the number is 992-272-827. People can also go to NCQA's website, ncqa.org/SNP. And then if you scroll down to the right, you'll see SNP Educational Session link. If you click that and open it, there will be instructions to log on to the WebEx that has the correct information, or they can go on to the cms.gov/live and watch it sort of via YouTube. We also have on the NCQA SNP website all the slides, the conference, the session agenda. So all that information is there as well for people who want to print it out or have it for them or forward it to others. So just, once again, the number is 992-272-827. Okay, so hopefully that gets resolved. But for everybody in the room, welcome and thank you for bearing with us for a few moments on that. A couple of quick housekeeping. Hopefully everyone has found the cafeteria and bathrooms and things. That they have not, bathrooms are at the end of the hallway that you just came in where the registration is. The cafeteria is if you go back out towards security where you first came in. If you take a right, there's a set of stairs. If you go down that staircase and then make a left, you'll see a large cafeteria. There's food there. There's coffee. There's a coffee station. So if people need to, during breaks or anything, grab a cup of coffee or water or juice or something, you can feel free to go down to the cafeteria. When we break for lunch, that is pretty much kind of a captive audience. If you leave the building, you have to go back in through security and get checked in and signed in by a CMS employee. So we are sort of highly discouraging leaving the building. Plus, you'll have to come back through the outside security gate with your car as well. So please just stay here. The cafeteria is large. It has a full service options of all different kinds of foods and choices. So we recommend that everybody stay here for that. And we've made enough time available for the lunch break. And for those who are on the WebEx or watching the CMS Live, when we do the break, you can just sort of bear with us during those periods of time. We'll be during the break, and you can log back in prior to that. Just a couple more things. Just remember, to silence your phones. And then the wireless, I understand there is wireless available, but from what I understand the instructions are, you actually have to manually add the network to your phone. It doesn't broadcast freely, so when you go to look for it, it won't show up. So you actually have to manually add it, and there's instructions on that board just outside of there. I believe the network is called Freedom, but there's some instructions on a board right outside by the registration table which will show you how to go ahead and add that network. So with that, I want to just quickly say thank you again, welcome, and I'm going to introduce Susan Radke, who is a contract officer here at CMS, and she is going to introduce Danielle Moon, and we're going to go ahead and get started officially with the program. So thank you again.
Good morning, everyone. We're so glad that you're here and that you made it safe and sound through, from wherever you are living across the nation. I'd like to introduce to you Danielle Moon. She is a member of the Senior Executive Service at the Centers for Medicare and Medicaid Services, where she oversees the Medicare Advantage program. During her 17-year tenure at CMS, Ms. Moon has served in a variety of leadership and technical advisor positions throughout the agency and in the Office of General Counsel in the Department of Health and Human Services. Prior to her current position, Ms. Moon served as Deputy Director of the Medicare Enrollment and Appeals Group, which is responsible for Medicare beneficiary enrollment, eligibility, and appeals policy. the Medigap program, and private health insurance reforms. Ms. Moon received her Juris Doctorate from the University of Maryland School of Law and is a member of the Maryland Bar. She has a master's in public administration from the George Washington University. And with this, I introduce Danielle, and I hope you all have a good morning.
Hi, good morning, and thank you, Susan, for that introduction, and thanks to Brett and the folks at NCQA who've been working this morning and 4 weeks prior to this, putting the conference together with us. And thank you all for joining us here, both on site and then soon online through our webinar for the Medicare Advantage Special Needs Plans Educational Conference and session. We believe that you will find the information presented here to be truly valuable, and that will help you in your efforts to improve care for Medicare beneficiaries with special needs. Special needs plans, as you all know, offer the opportunity to improve care for Medicare beneficiaries with special needs, primarily through improved care coordination and continuity of care transitions and protocols. As I'm sure you're aware, the Bipartisan Budget Act of 2013 has reauthorized the SNP program for one additional year through 2015, through the 2015 contract year. For the past several years, we at CMS have become increasingly focused on the care management processes of SNPs, since your plans are responsible for our most vulnerable beneficiaries. And as a result, 2013 has been very busy for us here in collaboration with you in the industry and NCQA and other stakeholders. And we've been working on a variety of initiatives designed to improve the Special Needs Plan program. So I thought I would take a few minutes this morning and walk through some of the recent activities and some of the things that will be coming up in the future. First, with respect to our model of care, we have revisions pending that we've shared with you. And the model of care, as you know, is unique to special needs plans and provides an infrastructure for promoting quality care management and coordination, and is considered a vital quality improvement tool. As many of you know, we recently revised the structure of the MOC in an effort to make the MOC elements more concise and cohesive. So we've modified the MOC to the structure to take it from 11 independent elements to 4 elements. Importantly, all of the same information is included in those 4 elements, but we believe the new structure will enhance organizations' understanding of the model of care and make development of the model of care easier. We also embarked on a new SNP audit protocol and completed several SNP audits in 2013. We used this first audit year to gain insight into the best approaches for conducting audits in subsequent years. Based on the audit results, we've identified some best practices that Ann McMillan from CMS is going to share with you later today. And we will discuss also the particular aspects of the audited MOC elements that caused particular concerns or areas of concern for plans. I would like you to know, too, that we have worked to clarify the protocols and guidance to SNPs to address possible misinterpretations. And our experience and lessons learned from the audits this year will be useful in considering our 2014 audit protocol. So we'll continue that process of, as we've done with our program audits, of learning from our experience and as we revise and update protocols in future years. With respect to our S&P measures, the structure and process measures and reports and their MOC summaries, we are in an effort to be more transparent and to better serve our stakeholders. We will be posting this S&P, as they're called, the S&P measure reports for 2010, 2011, and 2012 on our website and on the SNP website, as well as the quality website. We will notify you through an HPMS memo or an email blast when we post them, and we'll give you the link to the pages. We also announced last fall, at the end of September, in our memo about public reporting of the MOC summaries, that we would be posting summaries of all approved MOCs during the first quarter of FY contract year 2014. As indicated in that memo, we'll be giving you all the opportunity to review the summaries in advance for accuracy or any other concerns before we post them. And both of those efforts are, again, really driven by our desire to be transparent to our stakeholders, to the public, to other organizations, and in response to questions and inquiries we've gotten about what's in the models of care, what do they look like. Advocates have asked us, people who would find that helpful in maybe helping to figure out what special needs plan best meets their needs have asked us for that information. And rather than share with them the MOC in its entirety for obvious reasons, both the readability of that for most who are not working in the details of that, but also to protect any proprietary or confidential information that organizations might have, we've worked with NCQA to develop a summary template that you'll all be able to take a look at. But again, we believe that's very important. And also, I think it's important for you all to be able to show there on the CMS website, in addition to whatever you might post on your own websites, what you're doing in your model of care and how you're doing on the structure and process measures too. I'll also add a brief note that we'll have upcoming annual trainings on the model of care that are led by NCQA. Those are scheduled for January 21st and 23rd, which is just next week, and we'll be providing more details on those later today. We also intend to release our updated Chapter 16B, which is the chapter of our Medicare Managed Care Manual that applies to special needs plans. As you may recall, we shared with you a draft for public comment last fall. We've incorporated and received and incorporated comments, and we'll now be ready to release that later this week. And I think a lot of the revisions were clarifications and kind of fleshing out further some of the guidance to be more helpful to you all. It will be effective generally for the 2014 contract year. With the help of CMS staff, NCQA, and representatives from 4 plan sponsors who are going to be presenting today, we have a very full agenda. We're going to be reviewing the new MOC elements and the scoring guidelines. We'll provide an overview of key special needs plan reporting requirements and review how special needs plans performed on the S&P measures and HEDIS measures, because you know there are some SNP-specific HEDIS measures, and the MOC approval results. We'll also provide you with an overview of the 2013 MOC audits, discuss the protocol, share common findings, and discuss best practices. And we're also very pleased to have several organizations here who are going to be doing best practices related to care coordination, care transitions, and reducing readmissions. This is an opportunity that we first started on the program audit side, where we had organizations come in and provide some best practices from our high-performing Medicare Advantage organizations. And I think that it was found to be very useful for everyone to be able to come in and see what other organizations are doing and then be able to ask them questions. So we're trying to continue that trend here with the SNP MOC audits as well. I believe you'll find that today's sessions are going to be very valuable and informative. I encourage you to engage, ask questions of the presenters, and afterwards. We really are pleased to be able to host you on site as well as online, and we look forward to continuing to work with you in the future with respect to improving and continuing to support the special needs program. So now with that, I'll move into our first session by which will be from Susan and from Brett. Thank you very much.
Good morning again. So sit back, pretend this is the Good Morning Show or Good Morning America by Brett and Susan, because we will be talking all about the models of care and results as you know throughout the morning. I'm left-handed, so this is a little difficult here. Okay. Our objectives for this morning and for this presentation is to talk about the model of care statutory and regulatory background, to discuss the purpose in revising the models of care, and to provide an overview of the revised models of care. I found it interesting because while I was researching the historical background on the models of care, I was on the other side in 2003. I was working with UCare and Medica and all the health plans in Minnesota to be transitioned into a special needs plans. So I didn't get to know the history of how the models of care developed. Actually, the models of care have been required since the beginning of time, in 2003. It started out with 8 elements, and I thought that was very interesting. Throughout the years, though, Congress has enacted and reauthorized the SNP program and made new requirements for the SNPs and the models of care to ensure that SNPs provided the needed infrastructure to both quality and implement care management and coordination processes for beneficiaries enrolled in these plans. The Medicare Improvement for Patient and Providers Act of 2008 seems such a long ways back, doesn't it? It's Public Law 110-275 required all SNPs to submit an evidence-based model of care for CMS review during the MA application cycle. MIPA added some new requirements to the SNP model of care. Beginning January 1st, 2010, all SNPs were not only to have evidence-based models of care with specialized providers, but they also were then required to have care management and coordination services. MIPA added the requirement to perform an initial health risk assessment to be conducted annually, and then to be conducted at time of enrollment, and then to be conducted and reassessed annually. It also required that the health plan develop an individualized care plan and have an interdisciplinary team in the care management of its beneficiaries. More importantly, in Section 1859, the Patient Protection and Affordable Care Act, which was recent 2 years ago, stipulated that effective January 1st, 2012, and subsequent years, all SNPs must submit an evidence-based model of care to CMS for NCQ evaluation and approval in accordance with CMS guidance. At that time, we then revised the models of care consistent with regulations 42 CFR section 422.101F and 422.152G. So that brings us up to the present day. What we did in terms of reorganizing the 11 MOC elements was that we asked for your comments, and we're so grateful for them. We considered all of your comments. Some we were able to accept, some we were not. But we reorganized the 11 elements to integrate the related elements, to promote clarity and enhance the focus of care on needs and activities, to highlight the importance of care coordination, to address care transitions as well as other aspects of care coordination which were not explicitly captured in the 11 elements. This is the most important part of your special needs program, is your model of care. It's your backbone. It is what you are promising to your beneficiaries on how you're going to provide care transitions and care coordination, and how you're going to provide benefits and services to your beneficiary. So this is no light matter. It's really important for you to understand that the model of care is your structure for your program. The revised 4 elements capture all the information that's collected in the 11 elements. And I'm sorry if I misread this because I don't have my computer glasses on. So I apologize. Your model of care organizes information from interrelated elements in a more concise and cohesive manner. It still remains consistent with the regulations. It continues to ensure that the model of care is the vital quality improvement tool and integral component for ensuring all SNP beneficiary needs are identified and addressed. These are the revised models of care that you had commented on and that are now final. The first element is the description of the SNP population. The second element focuses on care coordination. The third element focuses on the SNP provider network. And lastly, the fourth element focuses on quality measurement and performance improvement. With this discussion this morning, I'm not going to be going into all of the sub-elements because you will be having training next week. We just want to go over the overview of what the elements are. So in the first element is the description of the special needs population. It focuses on the target population, whether they're a chronic population, a duals population, institutional living in the community. It focuses on that specific population. It includes your general targeted population as well as those that are most vulnerable, frail, elderly, disabled. It targets the unique health needs of all the beneficiaries, including those who are most vulnerable. The second element is the care coordination element, and this is an element that we really want to highlight that has been basically added to the model of care in the restructuring. Care coordination ensures that your SNP beneficiaries' healthcare needs and information is shared across healthcare staff and facilities over time. As you know, care coordination coordinates the delivery of services and specialized benefits that meet the needs of the most vulnerable population, and not just the most vulnerable, frail, but also those who may be not as frail. It includes the health risk assessment. Then it includes the individualized care plan and the interdisciplinary care team. And I guess I want to focus on this a bit because care coordination is just such a vital aspect of getting your beneficiaries the services they need. I used to be a psychiatric social worker, and I worked for a care management, a behavioral health care management organization. One day I got a phone call, and the discharge plan from the hospital was that we're going to discharge Mr. So-and-so to Howard Johnson's. We're giving him $50, and he has an appointment to see Dr. So-and-so in North Baltimore County. And that is not what we would call a good transition plan. And I'm not exaggerating. This happens in the real world. So it's important that you realize that you want to follow your members through the whole continuum of care. And this is what the model of care gets at. The other focus is on the SNP provider network. The SNP provider network in the model of care has a specialized clinical expertise. The network uses clinical practice guidelines and care transition protocols. The plans offer initial and annual model of care training for network providers and out-of-network providers. The last element is the quality measurement and performance improvement element. This would be your discussion on your quality performance improvement plans. You're measuring your goals and health outcomes, measuring your special need plan member satisfaction, supporting ongoing improvements of your model of care, and communicating quality improvement performance results. So you always want to measure, you know that you have this promise. This is the promise that you're giving to your members, and this is your outline for how you're going to, work on providing benefits and services to your beneficiaries. And there's always need for improvement. So this model of care will focus on how you're going to do that, what your challenges are, and how you're going to be able to improve your model of care. We will be, like Danielle said in her opening remarks, having upcoming mock training and technical assistance calls. For models of care elements 1 and 2, as you can see, we will be having our training on January 21st from 2 to 4 Eastern Time. We will be sending out an HPMS memo later, most likely tomorrow since I'm here today, giving you, the call-in numbers and all that information. So please take a look at HPMS tomorrow or Wednesday. The models of care elements 3 and 4 will be held on January 23rd, and that's next Thursday from 2 to 4. These training is for not only for special needs plans, but also for the MMPs, so it's for both. Then we will be having a series of technical calls. The special needs plans and the MMPs will have a technical call. This will be a call where you'll come in and say, oh, I don't understand X, Y, and Z. And then it'll be a question and answer type of a session. That's going to occur on February 11th before the applications are due. And that'll be from 2 to 3:30 p.m. And again, we'll have call-in numbers for you in our HPMS memo. The next technical assistance call will be on March 18th. That call is only for the MMPs. Just a reminder, last year, the MMPs had 2 cures, and the special needs plans had 1 cure. We're doing the exact same thing this year. That's why on March 18th, this call is a technical assistance call only for the MMPs, because that'll be your first cure period. Then in April, there will be another technical assistance call that will be for both the special needs plans and the MMPs, and it'll be the MMP's second cure, the SNP's first cure. So that's why both are included in that technical assistance call. Okay, you don't have the NCQA information here, so we'll make sure we have that. The mock training and technical assistance calls, you would be able to contact NCQA, and I'm sorry this slide has deleted that information. It's in your packet, good, thank goodness. And any mock policy questions can go to the SNP mailbox at SNP, and that's an _ mail@cms.hhs.gov. And those in the operational side of the house will forward those policy questions to me, and I'll be more than happy to answer them. With that, I'm going to hand the mic over to Brett for his presentation. Thank you.
Well, good morning, everyone. It's a pleasure to see everyone again today. And for this session, I would like to cover the big picture with the contract year 2015 scoring guidelines, which is sort of the companion piece to the overall model of care that Susan was referring to just a moment ago. And while I will get into some high-level details of each of the requirements, that we are going to hold trainings, as Susan and Danielle said previously, on the week of January the 20th, and that information will be going out, as Susan mentioned, via HPMS. The information will also be available on our SNP approval website, which can be found at www.ncqa.org/SNP approval. That's all one word. And so we will have the training dates and times there and the WebEx information as well on that site, as well as any other additional information that you need, including slides and things for follow-up. So as you just heard, CMS has revised the model of care requirements. And in order to provide a way to assess and score them, we have worked with CMS to create a revised format to the scoring guidelines. And the goal of the scoring guidelines of the revised ones is to make the requirements more transparent and objective, both for the SNPs developing the models of care, as well as for CMS and NCQA as we review and assess them. We used NCQA's structure and process measures format, or for other MA plans, they might be familiar with it as NCQA standards for our private voluntary accreditation programs. So we use that format to revise the guidelines, as they are familiar to many SNPs and MA organizations. And also, as we heard in public listening sessions and in the public comment process, many SNPs have actually asked for such a change publicly, that they do mirror that format and that guide. So as we did revise these, just keep in mind that we had strict parameters that we did need to follow. And so you'll see that the language in the scoring guidelines do hew very closely with the language in the revised model of care sort of overall requirements. We revised the formatting to fit within our S&P Measures format and structure, but the actual requirements and intent are consistent with the model of care overall. As Susan noted, CMS issued a public comment process over the summer where stakeholders had an opportunity to comment on the requirements. And then CMS addressed those requirements, finalized the model of care, and has released that, I believe, based on that input. So that we then, based on what CMS's position was, we drafted the scoring guidelines based on that, and then held our own public comment in the fall to solicit additional comment and feedback on the guidelines and their version. And we have received many comments, some of which echoed comments provided to CMS in the summer, and I'm going to go into some of those comments as well as sort of how we address those in the finalized scoring guidelines, which are in your packet. But first, I just want to give you a quick structure of how the scoring will work. Scoring will be similar to previous years, even though we've revised the guidelines themselves. The basic scoring will remain the same. So each element has a range of 0 to 4 points, similar to the way it was previously. And so there'll be a total, and based on the number of factors within the elements that are addressed. So in this case, there are 15 elements now that it has been rolled up into those 4 main categories that Susan went over, and within that there are sort of elements that address more specific requirements. Each of those will be worth a total of 4 points. And so each plan's score will be determined by dividing their score, how many of those elements they got correct at the 4, 3, 2, 1, or 0 level. That would be your numerator, and then the 60, which is the total points, would be your denominator, and then that's converted into a percentage. So for example, a plan that scored 50 points, they'd get an 83.33%, which would be the equivalent of a 2-year approval. So just to note, CMS has kept that standard intact as well. So plans must score at least 70% to pass. 70 to 74 would be a 1-year approval, 75 to 84 would be a 2-year approval, and 85 and higher would be a 3-year approval. And the policy that was in place last year will be the same as this year as well, so that any plan scoring greater than 70 or greater after the first round of review, after the initial submission, that's the score that they get, and it stops at that point. And that's whether, depending on what the score is, they get a 1, 2, or 3-year approval at that point in time. If they have a score below 70 in the first initial review, they have an opportunity to cure. There'll be one cure, as Susan mentioned. We have TA calls that'll address that. They then have an opportunity to get higher than a 70. Whatever score they get at that point, regardless of whether it's what category it is, they would only be allowed a 1-year approval. So this is just a quick sort of graphic representation of what the scoring in terms of the elements, as I just described, looks like. As you can see, previously there were the 11 elements. Each element, in this case, had multiple, there were 11 standards rather, and multiple elements. And this year it's been rolled into the 4 standards. And as you can see, like SNP MOC 1 has 2 elements because there's a total of 8 points. MOC 2 has 5 elements, has a total of 20 points, and so on. So as I did mention, we held a public comment process this fall. and we did receive a large number of responses, so thank you for that. We appreciate your input and your feedback. Most of the comments came from health plans, not surprisingly, since this directly affects you. We also had a fair number of comments from other stakeholders, such as trade associations, providers, mental health providers, and so forth, and so we welcome those comments as well. As I had mentioned previously, we did have some strict parameters within which to develop and revise the scoring guidelines, but we did take the comments that we received very seriously and use them to finalize the language that we have for the scoring guidelines. And as you'll see in a moment, we did use that to clarify many of the questions that plans had or others that they submitted during the public comment process. And also, we'll get into much more detail during the trainings that we hold about what the expectations are, and we'll have much more of a feedback in the Q&A to hopefully address and clarify issues and expectations that plans may have at that point as well. So I do want to go over some of the quick major themes that we did hear during the public comment process, and then I'll get into sort of element by element what we've done to sort of address that without getting into too much detail. So some of the major themes we heard. One of the major themes throughout really relate to the model of care audits themselves, which I know plans have expressed interest in. So there were numerous requests to clarify the expectations and interpretations of the model of care requirements based on plans' audit experiences or anecdotal stories that plans heard from other plans that had gone through the model of care requirements. So there were lots of questions in there, and hopefully, as you see the finalized ones, it will address some of those questions and concerns. There were also calls to harmonize the model of care and the structure and process measures assessments. So in other words, really to coordinate the two assessment programs to make the requirements consistent and reduce plan reporting burden. And also comments noting that certain requirements in the MOC are existing Medicare Advantage requirements and are thus redundant. And I believe CMS received similar comments as well during their public comment process. On more of the kind of content-related issues, there were a fair number of comments about sort of the network model of the way HMOs, the way SNPs are set up now, versus sort of staff model. I think that many plans were interpreting this as some of these requirements, they're a network model, in which case they contract for providers and things, and so they don't have quite the same control as like a PACE program or a more staff model HMO, where all the doctors and the other providers and things are under actual employment and directly employed by them, and they have much more control. All of their systems are integrated, or it's one system, so they have access to all of the case records or care plans and things like that. And so we heard a lot of comments with plans saying we don't have that kind of a situation. We have a network model, and we don't have as much direct authority over the providers or access to some of the information that individual providers have. There were questions and requests, to clarify whether the guidelines are seeking plan level or member level data. So is it at sort of the aggregate level for the plan as a whole, or do you want data on each specific member, specific providers, and so forth? And then this is particularly true, I'd say, for MOC4, which addresses the quality measurement and performance improvement areas. And then there was a lot of focus, not surprisingly, on the health risk assessments, the individualized care plans, and the interdisciplinary care teams, with plans concerned about the need to conduct HRAs and develop an individualized care plan for every member. Many plans offered that the focus should be on the high-risk, high-needs members, and we'll get into a little bit more of that as we get to that part of the scoring guidelines. So now that I've laid out the major themes that we've heard from the stakeholders, I would like to provide the basic intent for each of the elements and discuss in general terms how CMS and NCQA have responded to that in our finalized scoring guidelines, which are, again, they're available in the packet. So first, though, I do want to point out that the overall purpose of the model of care is to provide a written narrative that describes what the SNP will do if it is approved by CMS, or if it's an already existing SNP in this case, what it is currently doing and how it does it. So thus, the narrative really is a promise of future performance, and as Susan said previously, a roadmap for how to achieve that and how to provide care for all of its beneficiaries. So let me start with MOC 1, which is the description of the SNP population. And the intent here is for the SNPs to identify and describe their target population including information such as health and social factors that affect their overall health, as well as the unique characteristics of their SNP type. So if you're a dual, talk about what your dual members look like. If you're a chronic, what your chronic members look like, and so forth. There was not a lot of controversial comments on this element around that, but there certainly were calls to clarify that the emphasis is on the process plans used to identify and describe the target population rather than the actual care coordination activities, which get addressed in MOC 2 and then somewhat in 3 and 4 as well. There were also a call to separate the social and health medical requirements into separate factors. It's factors 2 and 3, and certainly we agree and we think that makes sense, and we've made those changes. So element B really looks at the most vulnerable beneficiaries within your target population, and how their conditions affect their care and what services and resources the SNPs will provide to address their issues and conditions. And as I mentioned in the major themes, this is one of the areas where plans really requested clarification on whether this was plan level or individual level focus. And I just want to clarify that the focus here is on plan level information about your population. We're not talking about what do you do for every individual specific member in the narrative, but rather writ large, how do you care for this most vulnerable and sick population? What do you do? What are the services offered? How does their conditions affect what kind of services and needs and care that they need? Okay. So moving on to MOC 2, which is really one of the larger requirements in that there's 5 elements here, and this addresses the care coordination component. So element A for MOC 2, and the intent really here is to describe the administrative and clinical staff roles and responsibilities. And we did make some changes and clarifications to the guidelines based on the public comments. So we did revise the language in Factor 2 that, to clarify that oversight functions are related to the specific population being served in terms of if you have to show provider licensure and competency verification. It really is about, are they competent and licensed to address that specific target population, which they should be, since that's who your population is. For Factor 4, there were some comments around the contingency plans, and is that at each individual level or is that the plan level? And so we do want to clarify that this is really, this is what are your contingency plans for your overall, for your SNP and how it operates, and then certainly there can be different plans for different types of degrees of issues, something such as a weather-related issue versus you have staff departing, and how do you address that and deal with those kinds of gaps. And then on factors 5 and 6, which really look at contracted staff, we wanted to clarify that this does not mean your contracted network providers. This is the staff that are employed directly by you and work for your organization. This is not network providers. That's addressed in MOC 3. So element B looks at the health risk assessment tool. And the intent here is to describe the process for using that tool to inform development of the individualized care plans, as well as identify and stratify members by level of need and care. And CMS, just to clarify, CMS does require that all members must be assessed. That's a Medicare Advantage rule that within 90 days new members must be assessed, and then at least annually thereafter. So that is just to make that statement clear. That is the expectation. We do recognize that not all members will be able to be reached, nor will some members either agree to the assessment or to participate in the development or ongoing sort of management of their care or their individualized care plan. We recognize that. CMS recognizes that. And so really what we wanted to clarify here, and we can go into more detail during the trainings, is that what we want to see is, what do plans do about this? How do they address, making a good faith effort to reach out and contact members to get them engaged, and what do they do if they cannot? So it's really just more about if you identify needs and challenges, what do you do about it? How do you address those? Okay. Element C, sort of leading into it, is about the individualized care plan. And here it's really to describe the elements of the care plan and then how it is developed and updated. Again, to clarify, the expectation is that all members have a care plan, and that plans should develop those individualized care plans based on each member's level of need. So we recognize that some members are very high need, high risk, and they need a lot of services, they need a lot of contact, they maybe need a much more active or ongoing plan. Some members are fine for the most part, and they're okay and they're stable. And so maybe the plan is just check back with them in 6 months and make sure they're okay. We recognize that, and we're allowing the flexibility to address that. But what we ask is that the plan describe what they do for different members at different levels and how they address that. Okay. Moving on to element D, which is the interdisciplinary care team. The intent again here is to describe the interdisciplinary care team, including who is on it, their roles and responsibilities, and how they really, what are their roles to improve members' health. Excuse me. We want to make it clear that we don't expect ICTs to meet face-to-face. There were lots of questions and comments and concerns about, does every single team have to meet face-to-face regularly? We're in a network model. Physicians work across different areas, different specialties. They may not always be able to get together in the same room. We agree, we understand. I think the language has always been in there that it's basically more about just describe to us what are the different types of methods you use to work together and to coordinate care and to communicate pertinent information. And then plans, just really the key is have plans describe what you do. For element E, which is around focusing on care transition protocols, here the intent is to describe how the SNPs coordinate care transitions and communicate across settings and providers and those who take care of the members. For factor 2, we had there was some language in there originally about providing staff credentials for what is the credentials that show that they're appropriate to be managing these populations, and we took that out. We realized that it's redundant. It's already addressed in the staff roles that we discussed previously, and there's no need to sort of reiterate or repeat that kind of information. It's already been addressed in element 2A. Also for factor 5, we revised some language to match the Agency for Healthcare Research and Quality language on self-management. We felt that their language was more robust, and we got that as a comment from one of our stakeholders during the public comment process. They had suggested that language, and we looked at it and realized that yes, it is a nice robust language, and I think it clarifies sort of what self-management is about, and so we put that in. It's really in the explanation, just to make it clear what the expectation is there. Okay, so moving on to MOC 3, which is about the provider network. Here the overall goal is to describe the provider network and how it is designed to address the needs of the target population. And so for element A, we did receive a lot of comments requesting clarification on whether this element is focused, again, on sort of plan level, high level, what is your network, how is it structured, how do you address the gaps or improvements and things, or individual provider level information, which again we recognize is not what we're looking for here. It's more at the plan level. And the focus is on provider network overall, just to make that clear. For factor 3, we removed language on credentialing. It wasn't in, we had it in erroneously. It was taken out of the CMS's model of care language, and so just to make sure that we mirror that, that's been taken out, and the credentialing language is no longer there. On element B, which is looking at the use of clinical practice guidelines and care transition protocols, the intent is really to show how plans ensure that care follows evidence-based clinical guidelines where appropriate. And I think that's really the key piece of that, is the where appropriate. We recognize that in many cases certain guidelines are not appropriate for certain members, so plans should really just identify and describe how they handle those situations in their target population overall. For certain high-risk folks, maybe a certain type of screening really is meaningless and inappropriate and could cause more harm than good. We don't expect those to be done for those kinds of patients, but really it's just about the plans describing what it is they do to address those, how they do it, and what's sort of the rationale for not always following those kinds of guidelines in those kinds of situations where it's not appropriate. Okay. Element C looks at training for providers, and we got a lot of comments, not surprisingly, in this area about, do we really need to provide training for each and every single provider in our network, and do we have to have them sign training sheets and attest to the fact that they've been through training and all this. And we heard that, CMS heard that. And so what we've done to address that is really change the language to show what plans should be describing is how they make training available to their network providers, how they communicate to their providers that that training is there, whether it's on the web or if they do hold in-person sessions or other kinds of trainings through a portal or some kind of computer-based training, so that it's available and it's being offered to the providers. So that is the intent. The intent is no longer, the expectation is not that that the plan documents the training of every single provider, but how you make it available, how you offer it, and communicate that, and what different ways do you use, what are the methods to provide training. Okay, almost done. We're on to MOC 4, which is one of the longer elements, again, because it's one of the key components here, really dealing with quality measurement and performance improvement. And this was really rolled in what the old MOC 2 and MOC 11 requirements are. So there's some different subtleties here, and I want to just talk about it briefly, and we'll get into much more detail in the trainings in the next couple of weeks about the differences between different requirements. But I want to just touch on it here for a moment. So overall, MOC 4, I think really the focus is on quality improvement, your quality performance plan, and how the plan seeks to get better, provide better care, and improve its activities. But there are some distinctions in what we're doing, particularly between elements A and B. In element A, the focus is on overall quality improvement related to the model of care itself. So one of the things we wanted to make clear, because I think there were a lot of questions and comments for clarification on this, we want to make clear that these are the plan level goals that measure whether the plan is addressing the key elements of its model of care. So are protocols happening? Are providers, is there communication happening? Are members being assessed regularly? Are care plans being developed and being followed? Are there interdisciplinary care teams? Are they coordinating with each other? Those kinds of things. So plans, internal quality goals that plans have related to that sort of overall model and structure writ large. So that is what, and measure that and see if they're improving and meeting those goals. So that's what element A is about. Element B, the focus is really on sort of more member-specific types of goals, particularly health and clinical measures for the target population. So and again, at the plan level, not for each member, but for members in general, are things like, if you have a diabetes SNP, for instance, are those kinds of goals related to controlling and managing diabetes for members, are those goals being met at the plan level? Is your population under control? Do providers know who they are? Are they getting the proper screenings and care? So that's really what the focus of this is. It's more on measures for the members as opposed to sort of overall plan operations, which is really what the focus of element A is about. Element C is about measuring patient experience. And so here the intent is to describe, how the SNP measures member satisfaction and how it responds to those results. We had many comments on sort of which survey should we use? Can we only use CAHPS or HOS? Are there other things we can use? Do we just have to use this? Why do we? And so what we want to make clear here and clarify is that there are numerous ways for plans to measure patient experience. We recognize certainly, at the SNP level, the benefit package level, CAHPS and HOS aren't fielded at that level at this point. So we recognize that you can use those, but you need to, discuss it. But there's many different ways plans can get at this. And what we're asking is that really the key is, plans should provide the details on the survey methods that they use, how they use them, how the data is collected, and how those results are then used to help inform their actions and their activities. It's not just you can only use this survey. You're not locked into one if you want to change it year over year. That's not what this is about. It's more about telling CMS what you use and how you use it. Okay. So D builds on that, which is really looking at ongoing performance improvement evaluation. So how well you're evaluating whether or not you're meeting your goals related to your overall quality of care for your plan and for your, at your patient level types of clinical and health care related, access related goals. And here again, in the public comments, we had some questions about, including lessons learned and challenges in obtaining timely data. Certainly, we understand that, in many cases this is new, or if it's a plan that's not operational yet, you don't always know if you're improving yet or what you're going to do. You might find results that are different than what you might expect. We recognize that this is about flexibility. It's about describing what plans intend to do to address those kinds of things. Are there activities in place to look at performance and measure it and improve over time and make changes and address those things that they learn as they do their measurement? Okay. Last one, which is the dissemination of the quality performance information. So here the intent really is to describe how you communicate your quality improvement plan to various stakeholders that should get this information, to providers, to members, to shareholders, to others, okay, to regulators. And here again, to clarify to some responses that we got about questions about this in the public comment, is really what we're looking for is the details on who receives the information, how often they receive it, and what methods it uses to disseminate information. And we recognize that you may use different vehicles, communication vehicles, for different audiences. It could be a website, it could be a provider portal, it could be a newsletter, it could be a shareholders report, what have you. It's just really about, again, describe the different activities and different methods that you use. I think you see a common sort of theme and what the expectations are here. And as I said, we will certainly discuss more of that during the trainings. So I want to stop there. I know that was a lot of information. Many of you probably have lots of questions. So I'd like to open the session up for questions. And also, for those listening on the WebEx, I believe the operator will provide some information for you on how to queue up and answer questions. You can either do that, for those on the WebEx, either you can queue up and and ask a phone question, or you can, there's a chat function in WebEx. If those who are familiar with that and comfortable with using it, they can type in their questions, and the operator will read those, and then we'll address those that way. So there are, for those in the room, we'll start with the audience first, and then we can sort of toggle back and forth between them as questions come into the queue. But for those who have questions here in the audience, we have 3 mics. There's one in the center, and then there's one on the right-hand side of my right, your left, and the opposite side as well over there. So please come up to the mic. If you could just identify yourself, name and organization, so we know who you are and we have it for the record, and then we'll be happy to answer any of your questions. And it looks like we'll start this woman in the middle first, and I'll bounce back and forth between the two sides. But go ahead, ma'am.
Yes, hi. I'm Dr. Mary Mayu from Coventry Health. My question is relating the training of out-of-network providers and how CMS envisions us doing that. Obviously, out-of-network providers are dispersed throughout the country, and I'm not really sure how we would do that.
Sure. So I would say, Susan, you want me to take it, and you want to?
You can go ahead.
Okay.
We'll team
tag team these. Okay. So I would say, as we said in the for MOC3 for the provider training, I think the issue here is really how you let those out-of-network providers or any of your providers know that trainings are available about how you run your plans, how your model of care operates, how your care management program works. So make those out-of-network providers aware of that. You can do that, as I said, in different vehicles. So you can have information posted on your website. There could be provider newsletters that get sent out. Maybe it's when you have, if you have teams that are in charge of sort of network adequacy, if they're going out and talking to different provider groups or provider teams, trying to either sign them up or do outreach. However, if you make them aware and available, I think that would really be the expectation of how this would, how this operates, is really just sort of, where's the information stored? How do you let them know about it? And how can they get access to it?
Yeah. We definitely, it's our dream, it's like our fantasy here, but we're hoping that it can really happen, that these out-of-network providers would actually want to know, what the model of care is and how best to serve their clients, patients.
We'll go over here to Valerie. Go ahead.
Thank you very much, Brett. Valerie Wilbur from the SNP Alliance. I don't have any specific questions about the high-level overview you just provided. I thought you did a great job in doing that overview of the changes that you made in relation to public comments. But I just wanted to thank you and Susan, CMS and NCQA, so much for all of the changes you just discussed, because many of the changes that you discussed are things that the SNP Alliance and our members have been concerned about for a long time. things like the expectation about provider training, the ability to have a virtual interdisciplinary care team, recognizing that there could be very significant differences in an individual care plan from one type of SNP and beneficiary population to the next. So we just really appreciate your taking to heart all of the comments we've been submitting over the past couple of years, especially most recently in the last 2 comment periods. So that's my comment and my offer of thanks. But my question is, do you know when the slides for the model care training next week will be available? Will they be available in advance so that we can review them before the call?
We're working on them now. We've been kind of pretty inundated in putting this together, and we recognize that we will be using some of this to adapt and get those out there. Chances are, if they will be available, it'll probably be about a day or so before. It'll be, pretty much last, kind of a just-in-time type of a thing. They'll certainly be available, obviously, the day of the training. We'll do our best to make them available prior to that. If we do, usually we'll send them out for the folks who have registered, through the WebEx. We have information. We can make them available. We'll put them on our website. But I can't promise that they'll be there in advance, and if they are, it'll probably be about 24 hours.
Good morning. I'm Jennifer Cleland with Health Partners, and again want to echo Valerie's comments about thank you for being so responsive. There's been some really good news, I think, in your updates this morning. One request would be that for the technical trainings next week, I think we're all interested in the goal of achieving a 3-year approval. And so, and I think it's in the beneficiary's best interest and CMS and NCQA's best interest as well as the plans. And so to the extent that you can provide detail about your expectations for compliance and method of evaluation, that would be very helpful because we really have just one shot at this, one chance. And so we'd like to do our very, very best and want to make sure we're meeting your requirements. So if you could please be as detailed as possible on the trainings, that would be terrific.
We certainly will do that, and we will, given the time allotted, there's a lot of information. We will try to go in as much detail as we can. Certainly also we would offer that it is a back and forth during the training, so we'll have live Q&A when we stop at each element. So you'll have an opportunity to ask a question, seek additional clarification, and we would certainly ask that you do so. If you're not sure about something, we're happy to take as many questions as we can, and even if we sort of run out of the time, we will be happy to follow up and provide that detail. And we'll also have follow-up technical assistance calls where it's kind of a sort of a live Q&A where there's not a format, but it's just call in if you want clarification, if you need information. That's available. The other recommendation I would say is the guidelines are now available to you. They're in your packet, and they'll be posted on our website probably today if they're not already up right now on the SNP website at NCQA. And I would say look at them and read them carefully. There is detailed information about sort of, there's the element, and then there's each factor clearly explains this is what the requirement is, and you need to get this requirement to get this points. And then there is an explanation that kind of lays out, provides a little more detail about what that requirement is. So I would recommend read them carefully, come to the trainings with those kinds of specific questions about what you're not sure about. I think that will help everyone. And if you have the question, somebody else probably does too. So.
And I do have one tip for everyone. Please, a 3,000-page model of care is just not going to work. I'm telling you, we have had them. I think what happens is when you go in the packet and you look at the upload document, it's exhaustive. And you're thinking, oh my gosh, how can I meet all these elements? And so what probably ends up happening is you want to put in all your documentation. You want to put in all your quality documentation and all your procedures. We really don't need that. We need succinct summaries of what you're actually doing. We don't need your appendices. We don't need your appendices attached to your summary. We have had 300-page MOCs. We've had 1,500-page MOCs and 3,000-page MOCs. Tip, tip, tip. We don't need it.
And Susan, Brett, hi everyone. This is Debbie Van Hoven, Director of the Policy Division here. I just wanted another tip in addition to prior to next week's trainings, the start of those trainings, you should certainly look at the scoring guidelines that are included in your packet today. But we will also be referring later in the presentations to a guidance memo that was released this February, I believe it was February 12th of 2013, which outlined, now this again was based on the original 11 MOC structure, but it did outline some of our expectations regarding those elements. I think if you take a look at that, I think it will be very helpful as you prepare for the new structure, which has been said is really based on those elements, though they were individually expressed in the last MOC. Now they're combined into the four broad domains. So if you take a quick look at that, I think that would be helpful as well.
Okay, thanks. I'm going to take see if there's a couple of questions over the phone, and then I'll get to you, Shelley. Thanks. So Danielle, the moderator, can you see if are there any questions over the phone?
Yeah, sure. At this time, we are enabling the phone lines. If you have any questions at this time, please hit #5 to unmute your phones and ask the question. Again, that's #5 to unmute your line and ask the question.
Okay. Well, I guess while we're while we're waiting for questions, I'll take one more from the audience, and then we'll come back. So go ahead.
Okay, great.
Shelley.
Hi, Shelley Smith with Health Value Solutions Consulting. My question relates to the greater alignment now between the model of care and the structure and process measures. And with this model of care really being described as your roadmap or your description of what you're going to do, whether that may result in some elimination of documented process requirements in structure and process measures moving forward, so that you could focus, instead of on a policy for how we're going to do satisfaction, since that's covered in the model of care, and instead of looking at that or submitting that a second time, you could focus on the reports and on the actual outcomes at that point.
I'm going to defer that one to you.
We can consider that. The structure and process measures really are different from the model of care. I think sometimes, I know it seems like there's duplication. Your model of care is your promise. This is what we intend to do. Your structure and process measures are, this is what we're doing. This is the documentation, and this is what we're doing. So I think it's important to try to, yes, they both feed into each other, but one's the promise, and one is, we're showing you, we're documenting to you how we are implementing this model of care.
Yeah, and we do certainly recognize that there is overlap now with some requirements, health risk assessment, some of the member satisfaction and things. But I think, as Susan said, one really is now, even the documented processes and some of the reports really is that evidence of implementation, that what you say you're going to do is what you're doing. We can certainly look to, in the future, create some more greater alignment and consistency, that what one says is then being followed up, and it's a more comprehensive assessment. But I think that's sort of, one step at a time. It's taking us, this year we did this, we rolled them up, and then we're able to put the scoring guidelines in a more concise S&P Measures format. One step at a time, we're working in that.
Yeah, so just a quick follow-up question. Then, if the model of care is the promise, would it be an inappropriate document to be using as a submission for structure and process measures, since it's a promise and not the document that says, here's what we've done? Just something to consider.
Yeah, generally the answer is yes. I mean, we've had this question before, can we submit a model of care as a documented process, something like a structure, like a policy and procedure. And really the answer, I hate to say this, but the answer is it depends. It depends on what the level of detail in the model of care is. Generally, the model of care is sort of a broad narrative, and so there isn't a lot of specific detail about how something is going to happen that would show that it's actually happening. The way we like to sort of think about when we do trainings for plans about structure and process measures is, reports are pretty obvious what they are. It's a report, right? It shows that there's proof something actually happened. But documented processes are really, if everyone on your staff, quit tomorrow and you had to bring in new staff, would they know what to do? Would they know how the plan operates? Would they know the things that they should be doing and how to follow up? So and generally, in a model of care, that level of detail is not always there. So many times it wouldn't be appropriate, it wouldn't meet the full intent of a requirement. It may be that it gives some context and helps the reviewer to see more of it. And some of them, we've seen, as Susan said, there's models of care that had lots and lots of detail where people embedded, or plans embedded, policies and procedures right into the model of care. And in that case, if it has all that and it shows what they're really doing at that level of detail for whatever that requirement is, then it probably would meet it. So it's really, you have to take it on a case-by-case basis. Yeah, and now, Danielle, are there questions that came in over the phone line?
Hi, Brad. There are no questions over the phone line, but we do have quite a few questions in the chat.
Okay, great. So let's take can you just read a couple of those questions over the chat, and we'll try and take them that way, and then we'll go back to, we have some audience members here waiting to ask questions as well.
Okay, sure. We'll start with our most recent question from Shannon Richardson. Her question was, for those plans that have received the 3-year approval through 2016, will they be required to submit their MOC with the new element structure in 2015, even if they are not applying for a new SNP or expanding?
No. If you do not need to submit your models of care this year, then no, there's nothing you need to do. If you are coming in with a service area expansion, yes, you would submit your models of care with the revised version.
Next question, Danielle.
Okay, this question is from Shannon. No, we did Shannon. Okay, this question is from Vicky D. What is the February 2014 MOC due date?
The model of care due dates are with the model, the SNP application. So your models of care, if you are a new health plan, a new MAO coming in to offer SNP, then you would go ahead and submit your model of care with the SNP application.
I believe the date is February 25th, is that correct?
Yeah, it's February 24th or 25th, and I'm sorry, I'll clarify that later on in the presentation when I have Debbie. 25th? Yes, it'll be the 25th. The application, I think, is going out tomorrow, but so you'll be able to see the application tomorrow, sometime tomorrow or Wednesday.
Take one more on the WebEx side, and then we'll go back to the live, and we'll toggle back and forth. Is there other QA chat questions?
Yes. Our next question is from Vicky P. If our MOC was approved for 2014 for 3 years, how do the revisions apply to us?
You would keep your model of care the same. You would then, when you come in for your renewal, then you would go ahead and use the new revised model of care in that submission. It's important, though, even if you're not submitting a new model of care this year, if it's not your renewal date, it's important to know what the revised models of care are now, so you can get prepared for when you write your revised model of care, in 2016, 2017.
Okay, we're going to switch back quickly to the audience questions. We'll take the gentleman in the middle here first.
Thank you. Tom von Sternberg, Medical Director at Health Partners in Minneapolis. In reference to your discussion on the model of care element number 4 on slides 17 and 18, I found it to be very applicable in terms of your comments about the need for the organization to pay attention to the fact that some of the quality outcomes may not be applicable to a SNP population, the frailty factors, et cetera. Mm-hmm. Help me reconcile that with our STARS measure requirements within HEDIS, and how so many of those quality measures are not able for us to demarcate why it is not relevant to our population. I find those two to be a little bit in conflict, because we struggle with some of the expectations around our STARS measures quality expectations, and that the statement which we would agree with so many of those measures have a less of an applicability for our frail, complex population.
I would say that's probably a question better asked for the folks at CMS who handle the Medicare STARS component, which is not us, it's not your division either, actually. I don't mean to pass the buck. I would say, though, this.
Well, you did it very nicely, I thought.
Thank you.
Yeah.
for future in politics.
We kind of view this as all together, you see. We
recognize that. And I think
yeah.
the thing we would say that the distinction, at least for the model of care, is that it's internal. So that it's looking at, you can use HEDIS measures or other types of quality indicators to see how you're doing as a plan to meet, your own internal goals. Whereas I think the HEDIS measures for STARS is to determine, the CMS determines how well you are meeting those goals. But we certainly recognize, that there are certain populations, particularly with SNPs, where we're talking about many small numbers and issues like that, where you've got very specific populations that not every single measure is appropriate for every single member, and that creates some small numbers issues and other kinds of things. But I think that's sort of beyond the scope of what we can address today. We don't have those folks in the room. So I appreciate your patience on that. Thank you.
And what you could do is you could go into the SNP mailbox with your concern and your question, and then I can go follow up with Liz Goldstein's group.
And on that. Yes.
Hi, I'm Seal Beshi from UCARE Minneapolis, and my question is, well, I'd like to see that you clarified what to do when a member refuses an HRA, but would you expect to see a care plan, or can we describe how we would handle that situation?
So I think your question is, if a member refuses, a health risk assessment, or you can't get a hold of them for the health risk assessment, then how can you develop the individual care plan? Well, hopefully that, if beneficiary wants assistance, that's why they're in the health plan. But I would take a look at what their needs are in terms of your visit or your initial visit, and then try to develop an individualized care plan. The health risk assessment should never be just an office visit. I just want to make sure you're clear about that. However, you can take information from that visit and put on the health care plan, this member has refused to participate, blah, 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 but this is what we know of what some of the health the needs of this member is, and we're developing our ICP accordingly. Does that make sense?
Yeah, it does. Thank you.
And I would say, just to follow up on Susan's answer, for the model of care, for the narrative that you're providing, I think really the key is about describing those types of actions, right? So what would you do if this situation occurs? How do you handle that? Is there a standardized process to address that kind of thing? And maybe it's, they don't have an active care plan, but based on the information, as Susan said, that we have about them, we develop this plan and we watch them and monitor them. And if something happens, then we step in and engage again. So it's really about describing what you would do in these circumstances, and how it happens. We'll take in the middle here, ma'am.
Yes, Deborah White, Medical Director of Performance Improvement, Healthcare Partners, New York. My concern is about being required to educate out-of-network providers on SNP. For our participating providers, we do an annual fax blast, because we do fax blasts as our newsletter. Mm-hmm. And in the fax blast, it gives them a Cliff Notes version of what SNP is about, and it gives them the link to the website where they can see a more detailed presentation. But if you're not participating, you don't get the fax blast. And so I don't know how to make out-of-network providers aware of the fact that there's education available. Can you help me with that?
Yeah, it's certainly trickier. And as I said in the presentation earlier, I think the key is providing, I know it's sort of sound redundant, sort of provide awareness, but possibly if it's maybe you have on your website information about the model of care training, maybe it's if you're trying to do outreach to those providers, if it's about network adequacy, you're trying to get them into the network or something, there's ways to do that. I think it's about discussing again, as I said, sort of a key theme here, describing what you would do or ways that you could sort of try and outreach or provide information to them. Again, I don't think the expectation is that every single out-of-network, particularly the out-of-network providers, have the training, or that you go out and talk to every single one of them. But if there is a way that if they inquire about it, if they want to know, that it's available.
Mm-hmm. The participating providers don't even inquire about it.
Yeah.
So what I'm hearing you say is that if you're targeting some non-PAR providers to try to get them to be PAR, some of that outreach ought to include the SNP education?
We would like you to be able to offer that education, that it's available to them. So I guess what you need to think about is who are these out-net providers? Do you know who they are, first of all? Can you find that out via an ICP? It could always, I'm just brainstorming here.
Yeah.
Could always contact that provider and say, hey, we've got training. It's on this website. Or is there something on your website that you can say to these out of network providers, go to our website? It's just something as simple as that.
Sure. And one thing, just to clarify, and this just dawned on me, the language, if you read it closely in the model of care and in the guidelines, is about network providers who regularly see your members. So it's not just sort of random out-of-network providers that are out there floating around. It's folks who maybe you have a beneficiary who just, that's their doctor, and they don't care if they're paying a little bit extra to get them out of network, or you don't have that special. And so it's those ones who are kind of a regular source of care or more regularly involved in that member's care at some level. And so in theory, you would probably know who they are because you're getting a claim, or they're listed in the care plan for whatever reason. And so it's those kinds of out-of-network providers that we're talking about, not just you live in a state and there's 10,000 providers and only 3,000 in your network and the other 7,000 should be reached. It's those ones who are sort of more regularly engaged with your specific members' care.
Okay, so basically out-of-network providers that seem to keep popping up time and again.
Yeah, members that are out-of-network providers that are, I forget the exact language, I don't have it in front of me, but I think it says that are sort of involved on an ongoing basis in your members' care, so that are engaged in there.
Okay, thank you.
And we can clarify further in the trainings as well. So I'm going to just take this question for this woman on the left, and then I'm going to go back to the phones real quickly, see if there's others there as well.
Okay, I'm Casey Hamblin from Viva in Birmingham, and it's more of a comment than a question, but it's around the population assessment, especially when you're talking about a large dual SNP membership. Some of those things that are, and I agree that health literacy information is important, but as far as data to be able to collect and report, I think that's a very difficult information to get and report. We submit our health risk assessments to our members via mail, so getting them to be able to explain their health literacy status a little bit difficult, or cognitive statuses. There's some things in the population assessment that for a non-institutional SNP or non-chronic SNP is going to be difficult to be able to produce.
We understand that. The issue with the health risk assessment, though, is that we are bound by law to provide a health risk assessment 90 days, and then annually thereafter, and if the condition changes. So what would be important in your model of care is for you to actually write down and document how difficult it could be to obtain health risk assessments. And if you can't obtain a health risk assessment, then how you're going to proceed with your ICP.
And the question is more around some of the specific data in the population assessment, such as over and over it's mentioned the member's health literacy level. This is very, very difficult information to get unless you're doing one-on-one. So reporting that piece of the information in population assessment, yes, we can do age, gender, top 5 HCCs, county of residence, utilization. We can give you a description of our members in that format, but when you get down to some of the more socioeconomic, health literacy, those kind of issues are going to be very difficult to report.
Sure, and I think the issue there would be quickly discussing that and sort of saying, and it may be that as part of your assessment, if you know that population, there's certain populations that based on other profiles probably also have health literacy issues, maybe it's sort of you document that level so that you can show in your care plan, there's some kind of algorithm that shows, if this patient lives in a certain county or they have certain other issues or socioeconomic factors, that health literacy may also be a factor. So, how do you sort of account for that and deal with it, and so that your care managers, whoever it is who deals with these patients and deals with the care plans, is aware of that and adjusts accordingly. That's really what, sort of this was about. And
We can take a couple more questions because I think we're late on our break.
We're running. I think we have a couple of minutes. We have about 5 minutes, so we'll do this woman in the middle, and then I think we'll try and take a couple from the phone lines as well, and if we have some time, we'll others from the audience. So go ahead, ma'am.
Okay, hi, I'm Sean Ellis. I'm a consultant with Compliance Strategies. I was wondering if you could elaborate a little bit on, it was one of your first slides, Brett, and it was the public comment major themes, and it was the request for examples and what the intent of that was. My impression from last year, listening to the trainings and the actual mock scores, was that the more examples you provided, the better your score. And without, getting to those 3,000-page mocks, I mean, what is the expectation?
Sure. Just quickly, the revised guidelines, if you'll notice, the revised, in fact, the model of care overall and the guidelines that then we took from it does away with all that sort of, provide multiple examples or 2 or more examples and all that. Part of the goal was to take some of that subjectivity out of that, right, and to streamline it. What I was talking about in examples here is many people said, many of the comments were, can you explain what you mean by, some of the questions like we've heard about, how do we deal with health risk assessments for people who won't, who won't or cannot respond or be actively engaged in their care plan? So can you sort of clarify or provide examples of how we would meet that or what that looks like? So it's not just about, can you show us 2 extra documented processes and a screenshot of that? So that, if you think of the examples that way, that's been taken out of the requirements, and really it's just about, if you read the scoring guidelines, it says, the model of care should describe X, Y, and Z. And so really it's about, what is that description? It's not then, what is that description, and can you show me 3 examples of how it happens?
Thank you.
You're welcome.
Yeah. So that's tip number 2. Tip number 2 is the examples are out of, you don't need to put the examples in. I think before some of you would get a little cure letter saying, oh, you did not have your 2 or 3 examples. You will not receive that this year.
We have one more here, Simone, and then I'm going to turn it over to the phone for a second. Go ahead, Simone.
Thank you. Hi, I'm Simone Scoopy with United Healthcare. And we had a question about if we have a 3-year approval, and so we're not submitting a new model of care this year for a specific plan, and we have an on-site audit, will it be on the new 4 domains or the pre-existing 11 elements?
It would be the 11 domains. You would be audited on the models of care that you have at that time. So, when is your renewal date? 2016?
We have a variety of them.
Okay. So, it's when, if your renewal date is 2015 and you get audited this year, you would be audited on your 11 elements. If you, like say for next year in the future, there's one of your health plans now has the 4 elements, then you'd be audited on those 4 when the time comes.
Okay.
Essentially, within the next couple of years, everybody will be on that 4-point element cycle.
Okay, thank you.
Okay. Can we, Danielle, are there other questions on the phone line?
If I could, Brett, I'm sorry, this is Debbie Van Hoven. I just wanted to add a little bit to what Susan just mentioned.
Sure.
I just want to, in terms of the audit work, just to be clear, and we're going to be talking a little bit more about that later today, but I just want to be clear that with the new structure of the MOC, the existing 11 elements they're not changed in any real way. I mean, when you look at the details within the 4 broad domains, as I call it, elements that we've talked about here, we really do capture the essence of what was the 11 independent elements. So do not worry in terms of the MOC. It's what we look at in terms of the MOC should be applied regardless of the current structure that you're approved under. So I hope that makes sense. And if anyone has any additional questions about that, there's some time later, certainly, as we talk about the audit for the upcoming year. Thanks.
Thanks, Debbie, for that clarification.
So, Danielle, are there questions over the phone?
At this time, we are going to enable the Q&A on the phone lines. If you have any questions at this time, please hit pound 5. This will allow you to unmute your lines and ask a question. Again, that's pound 5.
Are there any questions from the chat that are there, Danielle?
We do have questions from the chat. While we're waiting for others to queue up on the audio lines, we will take questions from the chat. I'll start with D. Hempel. In the past, the scoring was influenced by the number of examples provided. Is this still a critical component of the scoring?
So I think we just addressed that that answer in the question previously. So the answer is no, in the short answer. It's really about the complete description of the requirements based on what is in the scoring guidelines and the factors, and you'll see that when you review it. Is there another chat question? And then I think we have
Yes, there is another chat question. Is there a crosswalk from the old standards to the new standards?
There is no crosswalk, but just like what Debbie had just mentioned, the 11 elements are really captured in the revised models of care. We really just reorganized those 11 elements, and we've captured them in the current revised model of care. The only exception is the care transitions element.
Yeah, that's right. I'm going to take... I see Valerie on the corner. We'll take one question here from the audience and then maybe give one or two more on the phone, and I think we have to wrap it up. Go ahead, Val.
Okay, thanks, Brett. Valerie Wilbur from the SNP Alliance. I wanted to just follow up on the interchange that you had with the consultant that was making some comments about the relationship between the model of care requirements and structure and process measures. The SNP Alliance, again, appreciates the work that you did recently, which does reduce the duplication in things like if you have to submit a piece of process information in the model of care, that you wouldn't have to then duplicate that in the structure and process measures. But what we would like to see, as we've noted in our comments, is that there be greater alignment between the model of care requirements and the structure and process reporting, so that you don't duplicate process between the model of care submissions and the structure and process reporting. So, and making the structure and process reporting more outcome-oriented, which we know, has been a goal of CMS, to make reporting in general be more outcome-oriented, so that, for example, if you had a HRA requirement in the model of care, that the structure and process reporting would be how many people were eligible for the health risk assessment, how many HRAs did you actually do, how many were submitted timely within 90 days, so that the model of care requirements in the structure and process reporting would become more, this is the rule, this is the outcome, this is what the plan did, as opposed to having a set of structure and process measures that often don't align back, from our perspective, to the model of care requirements. And I know you said we have to take one step at a time, so we appreciate what you've done this year and look forward to working with you in the future on more alignment between what the actual model of care rules are and then what you're measuring in the structure and process.
Thank you. Thank you for that comment. I think we're gonna wrap it up now. I think we're just about out of time, and we want to make sure we stay on time and respect everyone's schedules today. So we're gonna take a break for 15 minutes, I believe, and start back up at 11 a.m. Yeah, about 11 a.m. So about 5 after 11. Come on back around 11 or so, and we will go get started. For those on the phone and on the WebEx, just sort of hang tight, put your phones on mute, and we'll see you back here in about 15 minutes. Thank you. Hi, everyone. We're going to try and get started in about 30 seconds or so. So if folks can just sort of wrap it up and get ready, we're going to go ahead and get started so we can stay on time and keep to our agenda today. Yeah, that's right. If there's people outside, if we can get them to come in too, please. We're going to go ahead and get started so we can stay on track today. Thank you.
Hi, hello.
Hi. For those on the phone, we're going ahead and get started in just a moment. So I believe that they'll make the open the phone lines back up in a little bit when we do Q&A.
Okay, I'm just trying to, hi, this is Diane. I'm just trying to see if you're sharing anything on the WebEx right now because I can't get any content.
We haven't started yet, so the WebEx should be starting in momentarily. Okay, thank you, everyone. We've got a lot of material to cover. I know this is the session that stands between you and lunch. So we appreciate your patience on this. We'll try and get us back on schedule here. So thank you, everyone, for coming back. Good morning again. It's me again. Can't get rid of me so easily. But this time, it's on a different topic altogether. Today, we're going to really be talking about an overview of SNP performance on the key assessment tasks that we do conduct under contract for CMS. So today I'm going to present key findings from our assessments on the following key contract tasks that we do work on with CMS, and those are the structure and process measures assessment, and this is from the 2012 measures review, which so plans submitted in October of 2012, and we finished the reviews and did the report and the analysis in the summer and early fall of 2013, and that's the data you're going to see for the structure and process measures component. It's also going to look at the 2013 model of care reviews, which was submissions that came in February of 2013 for contract year 2014, so plans that are starting up approval or renewal this year. And you'll see those. And then for the 2013 SNP specific, the HEDIS collection and analysis for plans that submitted this June for HEDIS data, which reflects data activities that occurred in 2012 but were submitted in June of 2013. So there's some different time frames, which explains why there's some different numbers in terms of overall populations and numbers of plans that submitted based on differing requirements. I'm going to go through this. There's a lot of information, but I want to go through it quickly so we can leave some time for questions and give time for Susan to do her presentation as well. So for the structure and process measures assessment, which is I'm going to talk about this first in this order, there are really 6 areas of focus, which are the six measures for HEDIS structure and process, looking at complex case management, member satisfaction, clinical quality improvement, care transitions, the institutional SNP relationship, which is only for the I-SNPs, and then SNP 6, coordination of Medicare and Medicaid, which focuses mostly on the duals. So I want to talk about some key findings here. So overall, SNPs did perform well on all 6 measures, but there was a wide range of performance across the measures as well as across SNPs themselves by type and size and other things, which I'll show you momentarily. We did change some of the measures in 2012 and revised some, added some new ones from 2011. So for those measures that remain the same from 2011 to 2012, SNPs did improve their scores, showing that they are making gains in quality in areas particularly in care management, care transitions, member satisfaction, and coordination of Medicare and Medicaid. So, as plans become more familiar with this, as they do it more routinely, scores tend to go up, which I think is consistent with what we see in other areas as well. We did as I mentioned, we revised some of the requirements as well as introduced new ones in 2012. And so for those, scores tended to be a bit lower, which I think is expected for something that's a newer requirement. One thing to keep in mind, though, as you do review these results, for the S&P measures is that the dual eligible SNPs really make up the vast majority of the plans in the program, not only the number of plans, but also obviously member enrollment. And so their performance really drives overall SNP performance. So when you see the results that you're going to see on the screen in a moment, it's really reflective to a vast extent of the results of the dual eligible SNP program. Okay, so some additional key findings here, and there have been some trends that we've noticed over the past couple of years. And one of them is that the I-SNPs, the institutional SNPs, tend to outperform the D-SNPs and SNE-SNPs on most of the requirements. Some things that are to note about this are that the I-SNPs tend to have the smallest enrollments and have a membership that really is easier to track, which may have some impact on their ability to coordinate care and communicate across settings and providers. Also, the I-SNP market is dominated by a small number of organizations, and the concentration drives, I think, a lot of the results and the aggregate for SNP. So, I mean, there's 5 organizations have almost 75% of the market, and 1 organization has 40% of the market. So their performance is really driving the results of the I-SNP performance as a whole. One thing to note that C-SNPs generally tended to have the lowest performance across all of the measures in this area. Okay, so for SNP 1 and 2, one thing to note is that CMS and NCQA did strengthen the requirements for 2012 by requiring SNPs to provide more evidence of implementation, particularly reports and materials, whereas in previous years we were looking just for the sort of the documented processes such as policies and procedures. In 2012 we kind of upped the ante and said we want to see more of the evidence of implementation. So that had an impact obviously on plan scores and plan performance as we raised the bar. We also added 3 new elements in 2012, which were at the time called SNP 1 elements I, J, and K. And they focus on satisfaction with case management, analyzing effectiveness, and identifying opportunities for improvement, and then implementing those interventions and follow-up evaluation. SNPs had lower performance on these new elements than existing elements, which I think, as we said, sort of you kind of expect if it's a new element that this performance it's new to them, so the performance tends to be a little bit lower. The way we'll see this is you'll see a benchmark, a national benchmark. Unlike HEDIS, where there is a percentage that's a benchmark, what we've done, because these are not continuous rates, it's based on the element scores between 0, 20, 50, 80, and 100%. We've developed the national benchmark, which is really the percentage of plans scoring either 80% or 100% on that specific element. So when you see something like 70% of the plans achieve the benchmark, what it means is 70% of the plans scored either 80% or 100% on that specific element. Overall, I think performance was strong for both the new and returning SNPs. We had differing requirements for new and returning SNPs, but were the ones where they both had to submit under the same areas. Scores were generally strong. Just to note that the majority of the plans in 2012 were returning plans, and we anticipate that that'll be the case again this year. For SNP 2, which looks at member satisfaction and implementing interventions in that area, returning plans were only required to report element C, which is the implementing the interventions. They'd already done the previous year, sort of doing the assessment and identifying opportunities, so now we wanted to see what they were doing in terms of implementing those interventions. This was a new requirement. Scores were relatively low. About 52.2% of returning plans met the national benchmark, which is, again, 52% of the plans scored either 80 or 100%, so about half were sort of in that area. New plans were required to report elements A through C, so all the elements. So assessing member satisfaction, identifying opportunities, and then also implementing, which were the A and B were the same. They hadn't changed from year to year. So here, a lower percentage of SNPs met the national benchmark than in 2011. It was 78.9% and 60% for elements A and B, respectively, in 2012. But it was 84.5% and 91.6% in 2011. I don't exactly know. I don't have an answer for why the scores were a little bit lower the next year. It just may be that it's newer plans and they're not as familiar with the requirements. SNP 3 looks at clinical quality improvements, and this in 2012 we changed the requirement here. So what it is requiring is that plans show statistically significant improvement on at least 3 HEDIS measures, and we use it basically plans submit HEDIS measures for the SNP requirements to us, and then we calculated their year over year. So plans, this is only applied for returning plans since new plans wouldn't have had a previous year's HEDIS submission. So we took their previous year's HEDIS submission and the current year HEDIS submission and did an analysis to see if they had statistically significant improvement on at least 3 of the 17 measures that they were required to report. And what you'll see is plans overall did very well. Duals had the highest scores in terms of the benchmark mean, so that 93% scored, got at least 2, showed significant improvement on at least 2 of the measures in that set. Also interestingly, larger plans outperformed smaller plans, and it was almost a sort of a direct relationship. The arrow kind of pretty much the slope goes straight up the line from smallest to largest in terms of enrollment size for plans. SNP 4, care transitions, which is sort of tended to be the most difficult set of requirements for plans over the past couple of years. And so generally, what we've seen this year as well as similar years is that overall scores for this measure were lower than for other SNP types, for other measures. Although, encouragingly, SNPs did show improvement on 4 of the 6 elements from 2011 to 2012. So plans are making progress. This is good news. They're improving their scores. And this was on elements B through E. Plans did show improvement, so that's good. That's good news. Particularly element C, which looks at the analysis of communications and coordination activities, so sort of plans doing an analysis of how well they do the care transitions activities that are required in A and B about communicating across providers and settings and communicating with the members themselves about care transitions. That score rose. The benchmark score rose from 39.3% to 51.9%. So that's a pretty big jump from one year to the next. One of the reasons plans still, I think, tend to have issues in this area is really about their ability to show documented processes pertaining to the requirements are strong, but many have still not shown the evidence of implementation of the process, which is really what is required to show full implementation here. So we're talking about actual reports and things about how communication actually occurs, when it occurs, if it occurs. So SNP 5 addresses, again, this is the institutional SNP relationship with facilities. It's only applicable to I-SNPs. So the D-SNPs and SNE-SNPs taken not applicable for this area. The I-SNPs, as I said before, are the smallest number of SNP benefit packages. And the institutional SNPs tend to score very high across the board on all three of the elements here, A through C. The lowest score being element B at 78.4%. Of the plans are meeting that national benchmark. So as you can see, the numbers are pretty high here. It's 80.4% met it for element A, 98% meet the benchmark for element C. So that's almost everybody got an 80 or 100% in that area. And that's even with the fact that requirements for elements A and B increased in 2012. So we added some more documentation requirements, and plans continue to show high scores. Looking at SNP 6, which is related to the coordination of Medicare and Medicaid, D-SNPs have more requirements for this measure than the other 2 SNP types for sort of obvious reasons, in that D-SNPs are now required to coordinate more between Medicare and Medicaid services. Data source requirements did increase to include reports or materials for elements A and B, which is related for the dual SNPs. For elements with no change in the requirements, scores, again consistent with what we've seen, scores increased from 2011. So that's good news. D-SNPs and I-SNPs had higher scores than the C-SNPs on the requirements where all 3 different SNP types were required to report the same elements. One area where plans did have some issues was around element E, which is network adequacy assessments for both providers and facilities where they accept payments from Medicare and Medicaid. So we're asking, many plans are good at showing their network adequacy assessments and analysis around the Medicare side, but fell down on describing what they do in terms of the Medicaid providers. So that's an area where I think there's still some room for improvement. So here's just a quick, we're trying not to be too sort of graph heavy in this presentation, but here's one that really just sort of shows the SNP 6 results on element E as I've discussed here. And so you can see, let's color come out okay. D-SNPs, I-SNPs tend to do actually pretty high on this. I think a lot of the I-SNPs generally, their membership is duals, and so they're used to working with Medicare and Medicaid providers. So I think that's some of some of what you'll see here. Good news, all three SNPs over, from 2011 to 2012, as you can see, showed improvement, the different SNP types. So there's, the light bar versus the dark bar on the left there. They did show improvement year over year. The other one I wanted to show you, which is similar to SNP 3, is that sort of on the graph here, it shows a direct correlation between SNP size and performance, with the larger plans outperforming the smaller ones with the slope going directly upward. Okay, so I'm going to switch quickly to, I know I'm going through this quickly, just to provide more context. The S&P Measures results and the results for the HEDIS report, which I'm going to talk about in a moment, are going to be released publicly on CMS's website on their SNP page. I'm not sure exactly when, but probably soon. We could probably get some clarification as to when exactly they'll be available before the end of the day. I think it's probably in the coming weeks, though, that information will be available. So the full report, which provides all the kind of detailed, top line results and analysis that I'm presenting here quickly, more detailed results will be available online on CMS's webpage, and then we can probably make it available on ours as well after that as well. So just to give you that information. So let me talk about now the model of care results quickly. So here in 2013, one thing I want to note is that CMS did raise the bar on the scoring. So any plan, as I had mentioned earlier in the day, so any plan that achieved a passing score of greater than 70% upon initial review no longer had the opportunity to cure and achieve a higher score. So it was only plans that had below 70 the first time, and then after that, regardless of their score, they had a one-year approval. So a few things to note from this review. As in previous years, many of the SNPs that were seeking service area expansions or new SNPs from an existing MA organization submitted MOC narratives that were identical or very similar to previously submitted narratives either the year before or 2 years before. And then so as a result, they received the same or similar scores as in those previous submissions, since they had the same or very similar information. Also, what you can see is that the majority of SNPs achieved a 3-year approval. 149 out of the total number of plans there achieved that. And there were 2 plans that actually were not approved last year. So here's a sort of the average score, final score for each element by SNP type. So you can see sort of the blue is the chronics, red is the duals, and C is the, green is the institutional SNPs. In kind of a reverse from the S&P, which I was a little surprised at, the I-SNPs actually have the lower scores across the board, although still the majority of them did pass and at least scored the 70%, got a 1-year approval at a minimum. You can see there are some high-scoring elements that stand out. MOC 1, which deals with the target population, the overall average scores were very high there. MOC 4, which is the interdisciplinary care team, scored high overall, which is particularly for the chronics and the duals, which is good news, right? The care team is in place. MOC 7, which addresses the health risk assessments, which is another sort of key component of the model of care, scores were higher there. And then MOC 10, which addresses care management for vulnerable populations, which is now in the new MOC 1 as in 1B. We also reviewed Medicare and Medicaid plans that are participating in the Financial Alignment Duals Demonstration Program. That's housed in the Medicare and Medicaid Coordination Office. The requirements is that for those plans, they also must submit model of care review. And so we did those for CMS as well. There were 10 states that participated in 2013. And you can see the states listed up here. Many of the organizations that participate in the SNP program are also participating in the demonstration program and have submitted models of care for their Medicare and Medicaid plans. And they used similar MOCs to represent their MMP submissions. There were certainly slight variations and differences because in many of the states there were state-specific requirements, and so those models of care were revised to address those state-specific requirements as well. But NCQA was not required to review that information. But we did coordinate our reviews with MCCO and made that information available to them and to the state reviewers so that everybody at least was aware of everybody else's reviews and what the level was at that point. As you can see here, there is sort of a similar performance trend as with the SNPs, in that the majority of the plans did achieve a 3-year approval. But one thing to note was that the MMPs were allowed 2 cures to achieve a passing score. So if they got anything higher than a 70 the first time, they stopped right there at whatever level they were. But if they had a less than 70 after the first initial review, they had 2 additional cure processes to get above the 70%. But as you can see, the vast majority achieved it on the first attempt. And then here is sort of the scores across by state. So this is, again, average scores for all submissions in each state. So what you can see, though, is that the MMPs, at least the plans, according to this, the high-performing states were Rhode Island and Vermont, followed closely from Washington State, which achieved kind of the highest overall average scores. Idaho and New York had the lowest average scores. This is similar. This graph shows scores by element. Since all the MMPs in the demonstration are for the duals, there are no results by type, since they're all just the same type. But again, here, similar to the SNP trends, similar high-performing elements, right? Element MOC1, MOC4, MOC10 have high scores here. So now I'm going to jump to the HEDIS results. And this reflects the results for the HEDIS measures, the subset of MA, full MA measures that the SNPs are required to report. And that list is here. We also have a more complete list, which has all of because some of these measures, you'll notice, have multiple indicators, which are reflected in the report, but are not on this, but in your packet, there is a more detailed list of all the different indicators for each of the elements and measures, for each of the measures. You can also find them on our SNP website. We have a HEDIS specifications. It's actually a volume that you have to publish, but it's available, and it has all the technical specifications for every HEDIS measure that we have developed. So for this review, again, this covers the 2013 reporting year and reflect care provided to beneficiaries in 2012. So here, 415 SNPs reported HEDIS in 2013. There are 17 measures, as I noted, and for many, as I've said, there's multiple indicators. And here, for the presentation and analysis, we treat each of the indicators as a separate measure. There is overlap between some of the HEDIS measures reported by SNPs and MA plans, and so where there is overlap, we compare results between the two. And to provide a complete picture of the environment, we distinguish between aggregate program performance and SNP benefit package performance. So program level analysis includes data from all SNP submissions, regardless of whether the plan met the HEDIS reporting guidelines of at least 30 members in the denominator, which would allow benefit package reporting. So that's sort of the distinction. Some key findings is we're looking back now over sort of a 3-year trend, 2011, 2012, 2013. The data show a steady improvement in SNP program performance on the HEDIS measures over this 3-year period. And I think that's consistent with what we find particularly in our private voluntary reporting and Medicare HEDIS in general when we do analysis, is that, trend over time is improvement, which is what we like to see. We believe that measurement leads to improvement. Overall, the SNP program performance was slightly lower for most of the measures than the Medicare Advantage program as a whole. However, the performance gap has continued to decrease. So the gap in performance is narrowing over the last 3 years. And for 2013, there were 8 measures where there was no statistically significant difference in performance between the SNP and the MA program. And there was, in fact, 6 measures where the SNP program performance is actually higher than MA performance for those indicators. There are some continuing performance differences among the 3 different types of SNPs. Dual eligibles this year had the most measures with statistically significant improvement between 2012 and 2013. So the D-SNPs are continuing to increase their performance, and that's good news, as they are, as we said, the majority of the SNPs and cover the majority of the population. Here is a quick slide that shows what I just discussed about the differences in performance here. It shows where SNPs either scored higher, lower, or the same from a statistical standpoint as the MA plans. And this slide is in there, so I'm not going to sort of go through all of it. One thing I do want to note, though, is that for some of the measures, they're not reported. So Care for older adults and medication reconciliation post-discharge are not reported by MA plans, so we can't compare performance between those with the SNPs. Also, the plan all-cause readmission measure, which all plans, including SNPs and MA plans as a whole, are required to report, but we're unable to sort of show differences because of some statistical reasons around risk-adjusted comparisons can't really be made using the t-test that we use for this. We're looking into that, with our analysis department for future years, but at the moment it's not, that analysis is not available. Just some trends, some more kind of bottom line kind of trends. The 3-year trend for the SNP program as a whole, as I've said, is showing improvement. 31 of the 40 measures, which is more than 3/4, showed statistically significant improvement from 2011 to 2013. And this is more than double the number of measures that showed improvement in the 3 years before that period, from 2009 to 2011. So plans are making really significant gains over the 6 years and certainly over the last 3. And then also looking at 1-year performance from 2012 to 2013, SNP showed significant improvement on 27 of the measures. And on average, scores improved by 3 percentage points over this past 3-year period. The 4 Care for Older Adults measures, which look at pain screening, advanced care planning, functional status assessment, and medication review, had an average increase across all 4 of those rates of 18.4 percentage points from 2011 to 2013. So that measure is really starting to come up quite a bit, and now that measure's been in place for I think 3 or 4 years now. So that improvement is a good sign. A slight subtlety is the trend for 3-year reporters. So this is plans that have submitted for the past 3 years consistently. They tend to outperform the SNP program overall, which is sort of any plan that has reported within the past 3 years, which shouldn't be that surprising, that these are plans that are more mature and have continued to measure and assess on an annual basis and have been involved in the program. They're more mature. They tend to outperform the program as a whole. I want to talk about performance by SNP type for a moment. On average, the DSNPs, the iSNPs, and CSNPs scored within 1.8 percentage points of each other for HEDIS 2013. So there really is a pretty narrow cluster of overall performance. Although the DSNPs did have the largest number of measures, with 9, with significant improvement between 2012 and 2013, whereas CSNPs and iSNPs had improvement in 2 of the measures. Also, DSNPs had a range of 10 to 16% point increases between 2012, particularly in the Care for Older Adults measures, which is where we saw some big jumps again. So I think that performance drives overall SNP performance, as I've said. One interesting note, though, was the CSNPs did have they showed a 39% percentage point increase, which was the largest that we saw in the Care for Older Adults measure, particularly in the advanced care planning rate in this 1-year period. So that's a really large jump and good to see. And then on the plan benefit package level performance, which evaluates performance at the benefit package level, and analysis represents results from individual plan performance, whether the plan had 30 or more members or not. Looking at those results across all the measures, 9 measures had large percentage point differences, which is more than 40 points between the SNP scoring in the 10th and 90th percentile. These measures also showed a large difference, at least 20 percentage points, between the 90th percentile and the mean score for those results, and thus represent sort of the greatest opportunities for improvement. And this is particularly true in the 3 Care for Older Adults measures. So while Care for Older Adults has increased overall, in the aggregate, the scores have resulted, there is still sort of a wide variation in how individual plans are performing and doing on that measure, and so there's still lots of room for growth and opportunities for improvement within individual plans. For 25 of the measures, more than 50% of the plans improved their results from 2012 to 2013, and for 5 of the measures, more than 70% of plans increased performance. So again, continuing trend of plans doing better over time, which is a good story to tell. Specific measures which showed the most improvement, colorectal cancer screening showed nearly 80% of plans showed improvement from 2012 to 2013 on this measure. And some of the other measures that's showing most improvement were 2 of the potentially harmful drug-disease interactions measures, which one looks at dementia and one is a total rate. And then the measures where there was the most variation and shows potential for opportunities to improve performance are, as I said, mentioned, the 3 of the care for older adults rates, which are advanced care planning, medication review, just 2 of them, excuse me, and then medication reconciliation post-discharge, as well as 2 of the board certification measures looking at geriatrics and family medicine. So that concludes the results of this. And again, the more detailed analysis and information on the S&P measures and the HEDIS measure results will be available in a report that we've submitted to CMS that they're going to release on their CMS SNP webpage probably in the next week or 2. I don't have the exact time, but we can get that for you. So I would like to just stop and see if there are any questions at this time. Danielle, if you can open the phone lines and let people know how to ask a question over the phone line, and in that time I'll be happy to take questions from the audience as well. I think we're actually almost running late. Okay. We have about time for probably maybe 1 or 2 questions. I think we're running a little bit late. Yes, ma'am, go ahead.
Anna de Groot at Kaiser Permanente. I have a question. SNP members receiving care in certified medical homes at the highest rate, is there any thought given on whether or not SNP 1 and 2 will continue to require reporting on it? Because in the commercial plans and the Medicare plans, those do no longer need to be reported on for the complex case management and the member satisfaction?
Sure. We have revised for 2013. The new SNP 1 looks different than it did in 2012 for the S&P measures. We've made some adjustments to try and sort of more align actually with some of the model of care and CMS requirements around the need for better assessment, better care planning, better coordination of care. So we're starting to move in that direction in that area, and then member satisfaction we've sort of kept intact. So we can certainly take that back and talk with CMS about how to, we're always looking to sort of evolve and these measures and this measure set and this assessment.
Thank you.
Sure, you're welcome. Take the gentleman in the middle here.
Dr. Tom von Sternberg again from Health Partners. Just a question, the reference of the measurement of number of physicians board certified in geriatrics. Mm-hmm. Is CMS aware of the shrinking pool of physicians going into the specialty for fellowship training? And any comments about if that's something that we as care delivery struggle with in terms of needing another pathway for some form of certificate of competence and special skill? We are not able to hire board-certified, fellowship-trained geriatricians to deliver care. Comments about that, or any things you can help us with in regards to advising American Board of Medical Specialties, some other constituents that might help that challenge?
Sure. I'm not sure if I know. I feel bad. I feel like I've punted the last 2 questions, so I apologize. It's a little bit out of the scope of what our goal with the HEDIS measure is just sort of to just capture what that rate is, but I certainly, if there's an ongoing problem, and I think there's probably concerns about ongoing physician shortages in a variety of fields and areas, particularly with an aging population. Obviously, geriatrics is one where there's a real concern. I would urge you as a plan, as others, to talk to CMS, to talk to the medical schools, their association about how to do that. Beyond that, I apologize, but I don't think I have a better answer for you in the short run. Susan may,
and then the other question is, we also continue to wonder why there continues to be an emphasis on a side-by-side comparison between MA and SNP. Mm-hmm. For what value? Fundamentally different populations, fundamentally different makeups, risk complexities, et cetera. Is there an expectation that SNPs should perform as well as an MA plan in these elements? Any kind of supporting information for that? Because we struggle with that comparison.
Sure. No, and I recognize, for many SNP plans, they are subsets of larger MA plans. And so we recognize that there are some freestanding, sort of standalone SNP-only contracts, but most of them are subsets, so that population is a subset of the MA population as a whole. And so we recognize that there I hate to use the sort of apples and oranges
Oh,
comparison.
you can use
but
that term if you'd like. That'd be fine.
maybe it's two different types of apples that you're comparing rather than an apple and an orange, because I don't think they're that different, because it's still, these populations. And we've tried to make sure that the measures that they are doing are appropriate for these populations, and we'll continue to look at that component. But I think CMS has been interested, and Congress certainly has been interested in, what is it that makes special needs plans special? And so I think that interest, as long as it's coming from them, will still continue to be there.
Thanks.
Rich?
Yeah, I have a follow-up question on this same issue of comparing SNPs versus general MA plans. How did you deal with the issue in that comparison where SNPs are part of a larger H number versus SNPs that are total SNPs,
right,
where those that information is different? And then the second issue is there any plans for doing some case mix adjustment or to account for social determinants of health as it relates to SNP performance measures? There's been 3 studies now in the last year, most recently in Health Affairs, that shows statistically significant differences in terms of scoring for plans that serve a high percentage of poor people. And if you assume that duals account for about 16% of the population fee-for-service, only 8% in general MA, and 85 to 100% in SNPs, there's just some populations that you address the same problem, and it's just more difficult to achieve a comparable outcome, if not, even a lower outcome. And so presenting this kind of information in public forum, and I understand this is a different kind of forum, and it's important for us to see these kinds of things, but I think it's important in broader public forum, and particularly communication to Congress, to help Congress as well as help other people understand that some of these differences, in fact, are understandable. And, I think it's important for us to find a way of getting at accounting for those differences. So to the degree you can kind of speak to how they're accounted for and what plans there are for addressing that, that would be helpful.
Sure. So to answer the first question first, which is a quick answer, is the MA plans have to submit at the contract level to HEDIS, so you sort of your whole population. And then for the subset of measures that SNPs have to report, they submit at the plan benefit package level, so there is that more discrete layer of submission. So that's the way we can distinguish which the population is. Now, in some cases, it may be a little bit of an overlap, or for the MA plan, it may be if they're a SNP only, it's the same population. But generally, that's the distinction to the first part of your question. You've got the contract level reporting versus the benefit package level. The second question is, I think, probably a little more difficult than that. It's really looking at risk adjustment, and these are harder populations to manage. Some of them are very specialized. But the one thing I would say, and I don't want this to sort of come off wrong, but is SNPs are in the business of dealing with vulnerable populations and populations that have higher need, and in theory should be organizing their networks, their care management model, their delivery, their benefits, all of that around how they deal with those harder to deal with populations. And so sort of the reason they're in that business is to address them and hopefully find ways to provide appropriate levels of care, that show that. And I recognize that's not, the end-all be-all, and there are some ways to look at risk adjustment as we go forward. I think some of it will be to better understand what the SNP populations look like compared to the larger MA populations. If we could get some more data from HOS and others at that sort of caps from the SNP benefit package level, we can better understand the risk profile of SNPs, and that would help us to do some of that risk adjustment as well.
If I can just make a follow-up comment in that regard, if there was comparison to comparable populations within a general MA plan, how they address their duals versus how the duals are addressed outside, and if they're measures that are most important for the target populations being served, I think that's another thing that might be looked at. But I think part of the problem here, and I understand it's difficult because the structure just isn't there to do it, but to continually compare SNPs against general MA plans on measures that are about general MA plans as opposed to about specialty care, begins to, over time, does a disservice. I understand the interest. Quite frankly, the SNP Alliance has a similar interest in being transparent and looking at comparisons. But it seems to us it's important to have the comparisons on the measures that are important to the subpopulations being targeted, as well as to address issues of differences that exist where there's known research to show why there's differences.
And we recognize. I think the one thing I'll say, and I know I have to wrap it up because I'm probably running over, is the one issue, though, is when we start getting specialized and trying to measure for more specialized and specialized populations is you come into the small numbers issues, around sort of there's just not enough people to meet the numerators and things. So that's one of the issues that becomes a problem where you've got very specific things. There just aren't enough people in a given year or measurement frame that pop up that you can sort of have some meaningful measure for. So I'm going to stop there and turn it over to Susan, and then she'll speak, and then I think we'll break for lunch. So thank you, and appreciate it.
While we're waiting, there we go. Okay. Thank you for being patient. I will try to get through this as fast as I can because I know it's at the end of the morning and you're eager to get recharged. We want to talk about what we use the data for. Basically, we are going to be using the data for public information. But in this part of the session, I will describe how we'll be using the information on the models of care results data, on the structure and process measure results, and on the HEDIS measure results. And I will be presenting the procedures and plans for public reporting of these results. The results of the model of care reviews inform CMS on how the SNP will identify and address the needs of all SNP beneficiaries and those that are most vulnerable and frail. They inform us on how the SNP needs to improve its understanding and delivery of their model of care based on our review. And then the reviews also inform us how the SNP will implement its model of care. The purpose of the structure and process measure data that we receive is to assess the internal and SNP process and operations that support and affect quality of care provided by the SNPs. It focuses on systems necessary for quality care, policies, your procedures, your reports, and your materials. It tells CMS how the SNPs implement their quality improvement program plans and models of care, and how the SNPs fare relative to SNPs of the same type. However, the S&P measures do not tell us how well you implement your quality improvement program and your models of care. And that's why this afternoon we'll be going into a session on the initial model of care audits. The data that we receive through NCQA is used to help inform us of the information I just said, and also to provide us with data so that we can assess our current policies and ascertain whether or not we need to change any policies or how we would move forward with the SNP program. The HEDIS measure data is used to measure SNP performance on important dimensions of care and service. The HEDIS measures make it possible to compare the performance of SNPs in specified areas. And the data, as you know, is used in the development of star ratings. I have to change glasses, excuse me. My computer glasses aren't working. Oh, that's much better. In response to inquiries from government oversight agencies, beneficiaries, advocates, and other stakeholders, CMS has decided to publicly report this data. We are preparing summaries of the SNP's models of care, and we will be posting them on the CMS website. And that detailed information is forthcoming. However, an HPMS memo dated 9/30/2013 was sent out outlining this process, which I'll go through in a minute. We will be posting the S&P Measures reports. They will be years 2010, 2011, and 2012, and the most recent HEDIS measures reports. Those will be posted on our CMS website hopefully sometime this week. The model of care summaries release is expected in the first quarter of CY 2014. And how we are planning on publicly reporting the models of care, as noted in the HPMS memo, is the summaries will be consumer friendly, and they're going to focus on the areas of target population, provider network, interdisciplinary care team, and the individualized care plan. Following a brief plan preview period to ensure that the summaries are free of errors and proprietary data, CMS will then go ahead and post the summaries. How we are doing this is NCQA is taking a look at the models of care. They're summarizing it in those 4 categories. We are reviewing it. Then we will be sending you the health plan, those summaries. You will have a week to look at the summary, make sure there aren't any errors, and to make sure that we have no proprietary data in those summaries. After the week is up, then we will go ahead and get everything ready and prepared to go up on the CMS website. We just want to note, though, when you have your period of looking for errors, we're looking for errors and we're looking for proprietary data. Please do not send us any information saying you forgot to add this or you forgot to add that, or we would really like to highlight X, Y, and Z. What's in the summary is in the summary. You just have to make sure that there are no errors in the summary. So basically, that's the procedure that we will be going through. Now we have any questions about this part? If please use the microphone.
Hi, Esther Morales from HCSC, and my question is, in the memo, it made it seem like those summaries were going to come to us in the 4th quarter of last year, or we just haven't gotten our summary yet. So we were wondering what the timeline is.
Yes. So we really apologize. We had something called the government shutdown. And we were all prepared to have this done before this year, last year was over with. But due to that unfortunate event, we will be sending you the summaries shortly. We're going to be sending out another HPMS memo, and we're hoping to have you're looking at it, and then everything out the first quarter of CY 2014, which is what, the end of March?
Right. Okay.
Yeah.
Thank you.
Susan, since the September 30th memo indicated that both the summaries and the scores will be publicly posted, can plans start to use that information, including the scores, in their marketing materials henceforth?
We'll need to talk about that. In the past, we have not allowed special needs plans to put that in their marketing materials. So this is something that we would need to talk about internally to see if we want to have that happen. But as of now, I wouldn't do it. Are there any questions from the phone or on the chat, Danielle?
At this time, if you have any questions on the phone lines, please press pound 5. This will allow you to unmute your lines and ask the question. Again, if you have any questions on the audio line, please hit pound 5. We do have a few questions in the chat.
Great. Could you read that question, please?
Okay. Okay, I do apologize. We don't have any questions in the chat. They were basically just visual questions.
Okay. Okay, well, since we are a little bit late and over time, we'll be adjourning. But before we adjourn, I want to let everyone know, and those who can hear me, we're having an issue with WebEx. For some reason, you can hear us, but you can't see the slides. If you are having an issue, you could text folks here that are here live and let us know what's going on. And we are doing everything right now to resolve this issue so that we can get these slides up, that you could see them in the afternoon session. Plus, they're going to be on the website.
They are available. So they are, just to follow up on that, the slides, the agenda, all the information for today's session is available on NCQA's website. So if you go to www.ncqa.org/SNP, so ncqa.org/SNP, and if you scroll down to the right-hand side there toward the bottom, you'll see a link that says SNP Educational Session. If you click that link, there'll be information there. You can find the slides from today's session so you can follow along for the afternoon and look at the ones that we previously discussed as well. So once again, the slides, for those who are having difficulty viewing them on the WebEx, they can go to ncqa.org/SNP, scroll down on the right-hand side to the link that says SNP Educational Session, and then they can find the slides for the program there. Thank you. And we'll see you back. It's a little after 12. We'll see you back about 1 o'clock. About 1, as close to 1 as possible, please, and we'll go ahead and get started. There's a cafeteria, for those who don't know. If you go back out to where you were towards security, if you go take a right and go down the stairs, there's a cafeteria there. They should be ready for the onslaught, so there's plenty of options there as well. Thank you.
I wonder if these are all.